Okay, in the background, I need somebody to tell me about the fox mouse. While we're waiting for Gerry to log back on, whoever's the best fox promoter guru can plan to tell me about it.
It's the mouse that we use for SARS, but I don't know that I know much about it. Its design precedes me, if you're wondering about that.
So you claim no responsibility for the choice.
I don't know that there's anything wrong with it. So I would say that while we're waiting for Gerry, in my experience with SARS, it's the amount of pathogenesis that you see happening, be it via viral loads or pathology in lung tissue, is quite dependent on what strain of both mouse and virus is being used. Typically, I would say, compared to human cases, there's less severe disease. It's more mild to moderate. Most of the mouse are not going to die. Those that we have using SARS are going to die because they'll be euthanized because they've lost too much weight, rather than some sort of a respiratory or renal sort of complication. Is Gerry back yet?
I just want to summarize first and show a few slides, and then Stephanie will give you the more recent stuff, but it's very similar, I think. Anyway, so I worked on coronaviruses since my PhD thesis on FIP a long time ago at Davis. And then I maintained interested in coronas because MHV in mice and NIH and elsewhere. And then over 10 years ago, I worked on SARS in different species, mice, monkeys, ferrets, and hamsters, and with mostly one strain. So the strain of the virus and the species makes a big difference. This is a summary table that it's fairly accurate. It's not exactly accurate. It depends maybe on your point of view. So for example, in humans, it's not just true with this first SARS virus. It seems to be true with MERS and with SARS-2. Generally, interstitial lesions are the most important thing, but other factors as well, and I'll mention that in the next slide. And mortality, of course, very high with MERS and SARS-2 and much lower with SARS-1, actually, or no, it's higher with SARS-1. Anyway, mice, different strains of mice are susceptible, but just barely. They get typical respiratory tract infection, clears in 5 to 7 days, and they don't have no mortality. But if you use aging mice or you adapt the virus to mice, it becomes more virulent. In fact, the mouse-adapted virus has develops mutations, which allows it to infect in more direct ways. And hamsters are I'll show you hamsters because they're very, very great interstitial lesions, but not quite the same as humans as well. Ferrets and monkeys are interesting. The real expert on pathology of these respiratory coronaviruses is our Dutch colleague and ACVP diplomate, Thies Kuken at Erasmus Medical School. And he's published a lot on all these different viruses. We tried to get him on today, but he couldn't do it. So in the United States, ferrets don't die, but in ferrets and monkeys die in the Netherlands, and they have more severe lesions. I don't know why. It might be related to the housing type being different. Okay, so the important thing I want to point out here is in humans, and you can see this, the slides that were published that Sandy just showed, the published paper of human lung lesions, which have been called DAD, or diffuse alveolar damage. I think this is a lesion that most animals, probably all animals, don't really get. It's been published that monkeys and some other types of experiments, you do get this, but it's kind of a stretch. And I've seen a recent paper on monkeys, which has focal edema, and they call it DAD. So you have to be real careful there. Stephanie will probably say something about this in her remarks. Anyway, so this is a very specific thing in humans. It's really severe, and it relates not only to viral infection, I think, of the type 1 and type 2 cells, but probably other factors related to the vascular system, thrombosis, and other things. massive hemorrhage was in some of those slides you showed. There's some online sites now of the human disease. Anyone interested, just email me. There's an NIH website of human autopsy cases and digital slides. And you can see the massive hemorrhage is amazing, and the hypertrophy, hyperplasia of the type 2 and type 1 cells. Anyway, so that's a big difference, I think. Okay, and then we're going to go to a few digital slides here. So first, I'm going to show you a typical mouse infection, at least in our experiences. Dr. Kanta Subaru at NIH, a virologist who led all these studies, and she's now in Australia at an influenza center. So I was lucky to get involved with her. But a lot of the experiments are like this. So this is day 3 in a 129 background mouse. You don't see much, but there are lesions centered on bronchial.
I got to stop you, Gerry. You're just
Yes.
sharing your PowerPoint. You got to switch windows.
Anyway, so here's a typical immunostaining. This is an antibody, actually hyperimmune serum from mice that survived. And so it's a mouse polyclonal, and you'll see there's plasma staining. You can see my hand, it's very small. In the blood vessels, the plasma stains, but the viral infected epithelial clara cells mostly are infected and get necrosis. There isn't much of any alveolar. There's a few cells in the alveoli that are positive, but very few. So that's sort of typical of different strains of mice. And even knockouts, interferon knockouts that we worked on, we thought that would play a role in the pathogenesis. It had no effect. Only one mouse strain, which I'll show you the last, had an effect on the pathogenesis. Okay, so this is a strain that was more susceptible, even at this is day 3. And the same antibody, you can see much larger areas of massive necrosis, more involvement of the more widespread involvement of the bronchioles, but still not much involvement of the alveolar cells. Maybe some, anyway. Well, what's interesting about this one strain is it dies, 100% death, but later. They recover from this acute infection and they develop lesions that progress. So here, this again is not DADs like in humans. So this is a day 7 in this knockout line. And you can see much more severe involvement of airways and alveoli around it, and necrosis and all kinds of stuff. But what's really interesting is by day 14 to 22, they get these gross lesions and grossly fibrinous peritonitis, just like FIP. And actually, these lesions, to me, resemble FIP, except they're much larger. So basically, this is H&E. They're focal lesions. There's necrosis and massive infiltration of neutrophils. There's macrophages on the outside. And outside here, you can even see large numbers of plasma cells. This is erythropoiesis. Lots of plasma cells on the outside. So if you stain this now, this is a stain using the hyperimmune serum. So all the plasma is staining. And so we do have specific staining in the slide. So in the macrophages surrounding the focal lesions, you can see, I'm trying to find a better area here. Here's an area. You can see these are the macrophages and they're positive, strongly positive. Also outside, the plasma cells are strongly positive, but they look different morphologically and they're actually not as intensely staining as the macrophages. So the virus is infecting the macrophages and the lesions by some immune unknown mechanism, still not studied. We published this over 10 years ago. Matt Freeman, who was at UNC, Ralph Barrick's virology group that Stephanie now works with, he's at University of Maryland now. He worked on this and he's still doing some work on this. And one of our colleagues at Hopkins is helping him with the pathology. So anyway, this is not obviously DADs. In this slide also, I think there's a piece of lung. Let's see, I can show you the lung. And I don't have the H&E, but I just have the, here it is. No, that's not the lung. The lung is in another slide somewhere, but the lung has the same thing. The lung has these large pyogranulomatous lesions, not a severe interstitial pneumonia, as you might expect. So anyway, so that was interesting. So the mouse basically gets a typical, with SARS-1, you might call SARS-1, but it's called SARS coronavirus, the first one. Just get a typical respiratory infection that clears. And in this strain, this knockout, which is STAT1 knockout, this was published by 2 different groups, the one I was working with, as well as Washington University St. Louis first published this. For for some reason not worked out yet, they get that. But humans don't get this, so we don't have to worry about it, although there is some evidence of infection of other tissues of humans, as Sandy mentioned. So the last thing I'll show you fairly quickly, this is a different species, and this is day, day 5. So you can see at day 5, there's more extensive lesions, interstitial lesions, especially, and thickening of the alveolar walls, inflammatory cells, neutrophils, macrophages present, and but most of the lung isn't that bad, and these animals actually get sick, but they don't die. And the airways, the alveoli have much more severe lesions than in the airways. You can see there are lesions in the airways, but not massive necrosis and so on. So using immunohistochemistry, this is, let's see, also day 5. And this is dramatic, and it's really probably related to the human infection. Alveoli are loaded with antigen, probably type 1 cells. In areas you can see flat cells. I can't go any higher, sorry about that. But most of these cells are flat. There's also some macrophages and probably type 2 cells infected. So this you don't see in the mouse very much, and it's more extensive in the hamster, and it's also seen in monkeys. Of course, the strain of the virus and the strain or species and strain of the animal plays a role as well. Okay, so that's all I wanted to show. I wanted to emphasize that the human lesions are not really seen diffusely in animals. There is a difference. Maybe some of you online, we have a great group online here, all my colleagues and friends. Many of you work with mice, and some of you probably work with this virus or one of these 3 viruses. Some of our colleagues are not online who are actually working with the viruses right now. Okay, thank you. Any comments, questions until Stephanie will present more recent research on MERS and SARS-2.
So, so I have one practical question, Gerry, which is this antibody staining with the hyperimmune serum that you used. Is that available? Is that something we can distribute?
I can tell it came from NID, and the person, Dr. Savaro, is not there anymore. But there is people that can, if you want to get it, I can probably find somebody that'll send it to you. The NID group working with it now is the Rocky Mountain Lab, and Dana Scott is the veterinary pathologist there that's been working on this. He's on the first monkey paper. I can put you in contact with them and so on. So, but you want probably a more specific serum. I think Stephanie will probably tell you the ones that she's used or that are probably commercially available, more specifically to specific antigens.
Well, I will say this actually looks very good, and partly I guess that may be because it's on hamster, but this is nice staining.
Okay, any other questions? Or you can wait till after Stephanie presents. We're not going to finish at 12:30. We'll go past, and I think that most people will be interested. So, you want to go? Let Stephanie go.
Yeah,
now,
I think we can go past. I warned people about that.
Gerry, there's a question in the chat box.
Okay, let's see if I can find it. Okay, maybe you can read the question to me. I'm kind of putzing around my screen now.
It was a question about which knockout there was. Was it the interferon knockout? But I think you told us it was STAT1 knockout.
STAT1 knockout only. And that's been published, and Matt Freeman's the senior author. You can do a search for Ward JM SARS, and you'll find 4 papers there, and one's by Matt Freeman who's at University of Maryland right now. And he has a lot of pathology that he did himself on the lung. It doesn't show much, but our supplemental figure shows all those STAT1 lesions that are great. The first paper on STAT1 from Worcester also had some pathology, but they actually missed most of the lesions I just described.
Quick comment, Chair. This is Marcus Bosenberg. The human side of pathology, including diffuse alveolar damage, is generally a post-ventilator phenotype, which you're not really going to mimic in any of the models. And I think that's probably a pretty important and relevant thing. Most of the pathology that you were showing seemed pretty multifocal, but nonetheless focal, which is really in contrast to DAD that one sees in a variety of contexts, which are almost all post-ventilator, not just associated with SARS. And I think that's something to keep in mind.
The hemorrhage, I would think the massive hemorrhage, right?
It's not just the hemorrhage. Actually, you get fibrosis, or hyalinization of alveolar spaces and things like that seem to correlate with a decreased ability to exchange gas. So it really, the name actually is somewhat accurate.
Actually, this is just a hamster again. I found the areas where there's protein in alveoli. There's one paper recently that describes this as DADS, but to me it's probably edema, but it could be other stuff as well. You can see that here. So you can, people take pictures of one little area and they say it's just like the human disease, and it really isn't.
Yeah, I don't think it is. I think the human side is a lot less focal and a lot more diffuse, but it's almost always post-ventilator. And it could be that the ventilation part is what's causing the common pathology across different etiologies for the lung disease. So I think if one had autopsy series in humans of patients that were not ventilated, that would probably be the most accurate view in comparing with the models.
Right. The one thing about the human one, the pictures that Sandy showed in the online website at NIH, you have great thickening of the alveolar walls by type 1, type 2 cells and macrophages, and that is dramatic, but that itself wouldn't kill the person, obviously.
Okay, Corey's got a couple more questions in the chat. She asked, is there any information on the similarities between IN infection of mice with MHV? The lesions that I've seen look more like the acute human disease to me. And then she also comments, were all of these scheduled sacrifices? I saw a way worse vascular lesion in some flu case found dead than in the scheduled sacs.
Exactly. Yeah, well, obviously, most of virologists kill the animals before, when they're sick, or when they're not sick, when they recover. So you're right. We didn't see the animals die, but the mortality is studied. In these studies, the animals, the stat ones did die progressively from 2 to 3 weeks after exposure from that lesions I showed you. But the other animals, the survival, they lost weight and then they recover. So it's maybe different with MERS and with SARS-2. Stephanie will tell you that.